Welcome to this special podcast episode of Diabetes Care on Air. I'm Dr. Alice Chang from the University of Toronto, and I'm delighted to co-host this podcast episode with Dr. Michael Rickles from the University of Pennsylvania. Hey, Mike.
Hey, Alice. Thank you and welcome, everyone. In this special episode, we will discuss an extremely important component of the February issue of Diabetes Care, the National Clinical Care Commission report to Congress. The National Clinical Care Commission was charged with developing recommendations to leverage federal policies and programs to develop and implement a new national strategy to more effectively prevent and control diabetes. Their report makes 39 recommendations that address diabetes at three levels: the population in general, the population with prediabetes, and as well, the population with diabetes. And so to distill this comprehensive advisement to the United States Congress, we are delighted to have several special guests joining us for this episode.
Yes, indeed. We are very fortunate to have joining us three authors of the report: Dr. Bill Herman, former chair of the commission and professor of internal medicine and epidemiology at the University of Michigan; Dr. Dean Schillinger, chief of the Division of General Internal Medicine at Zuckerberg San Francisco General Hospital and professor of medicine at the University of California, San Francisco; and Dr. Paul Conlin, chief of the medical service at VA Boston Healthcare System and professor of medicine at Harvard Medical School. In addition, we are joined by Dr. Nita Laitirapong, an associate editor of Diabetes Care, an associate professor of medicine and psychiatry and behavioral neuroscience at the University of Chicago, and an expert on the impact of healthcare systems, healthcare policies, and quality of care on diabetes outcomes. Welcome, Bill, Dean, Paul, and Nita.
What a group. Let's get started by considering the basis for the report. Bill, can you tell us about the factors and trends that inspired the formation and organization of your commission?
Over the past few decades, the medical community has generated evidence to show that lifestyle and medication interventions can delay or prevent the development of type 2 diabetes. In addition, an abundance of safe and effective medications have been introduced to control glucose, blood pressure, and lipid levels, and it's been demonstrated that appropriately timed interventions can slow the progression and reduce the impact of diabetes complications. Despite this evidence, the diabetes epidemic has accelerated in the US, and efforts to translate treatments into routine clinical practice have stalled. Between 2003 and 2020, the age-adjusted prevalence of diabetes among US adults increased from 10.2% to 13.2%. And between 2007 and 2018, the percentage of US adults with diabetes achieving the ABCs of diabetes care, including A1C less than 7%, blood pressure less than 140/90, and non-HDL cholesterol less than 130, have decreased from 24.9% to 22.2%. And finally, while the age-adjusted incidence of non-traumatic lower extremity amputations decreased steadily from 2000 to 2009 among people with diabetes, the incidence has increased progressively since 2010. The Commission reviewed these findings and concluded that the lack of progress in the prevention and control of diabetes is due in part to our failure to recognize diabetes as both a societal problem and a complex medical problem. It concluded that to successfully prevent and control diabetes, the policies and programs of both health-related and non-health-related federal agencies must be aligned and coordinated. And it was really this recognition that inspired the organization of the commission. The National Clinical Care Commission was in fact the second commission to address diabetes in the United States. The first commission, the National Commission on Diabetes, was convened in 1974 and issued its report in 1976. It was a hugely impactful commission and resulted in a number of activities at the level of the NIH, the CDC, the Veterans Administration, and the Indian Health Service. That report viewed diabetes as a biomedical problem with biomedical solutions, and it actually set in progress the Diabetes Control and Complications Trial and the Diabetic Retinopathy Study. It established diabetes research and training centers and established the Diabetes Mellitus Interagency Coordinating Committee, which got the CDC and NIH and VA and a few other agencies talking together. The National Commission on Diabetes also established the Centers for Disease Control and Prevention Diabetes Control Programs, and both the VA and the Indian Health Service diabetes programs. The limitation of that commission, though, was that it viewed diabetes primarily as a biomedical problem with biomedical solutions. 45 years later, the National Clinical Care Commission really for the first time addressed diabetes as both a complex medical problem, but also as a societal problem requiring societal solutions.
So the commission importantly recognized that federal efforts must involve multi-sector engagement and trans-agency collaboration, address social determinants of health and health equity, and improve access to healthcare. Of the recommendations provided in the report, 3 recommendations are considered foundational. So Dean, can you please walk us through each of these 3 foundational recommendations?
Yeah, absolutely. You're right. The 3 foundational recommendations were to address the social determinants of health, to ensure access to high quality care for all, and to address health equity. And the rationale behind those 3 was, as Bill mentioned, the recognition that a significant part of the diabetes epidemic, as well as a number of barriers related to the management, prevention, control, and management of both type 1 and type 2 diabetes, are a function of the social conditions and environmental conditions in which Americans are living today. And that unless we affirmatively address those conditions to the extent that we can through federal policy and practice changes, we will always, to a certain extent, be chasing our tail with the epidemic. And so a foundational recommendation is to address conditions like the food system, the housing system, the transportation system, et cetera, that significantly impact both the incidence and control of diabetes. And I can say from my practice as a primary care doctor in a public hospital, these issues are front and center every day, as important as what the insulin dose is going to be, or the changes in medications that I'm going to make are those conditions in which people are challenged to manage their diabetes. The second is implicit and obvious, which is people with diabetes especially need to have high quality, accessible health care. And while we as a nation have made significant progress in that, there still is significant room for improvement. Many people who are insured are still underinsured. Their benefits package don't cover the kinds of innovations and advances that the scientific community has been successful in achieving. And so we have inequities in access to care that are quite stark. And combining those inequities in care with the inequities in incidence and prevalence and complications, we naturally arrive at the need to attend to health equity. The disproportionate burden of the epidemic is borne by people of color and low-income communities. The inordinate amount of public monies, therefore, are spent on the care of people, publicly insured people with diabetes, really mind-boggling numbers that are consuming our healthcare budget and infringing on our budgets for social safety net programs. And so without attending to health equity concerns, our commission would not be doing its job well. And so we made that last one also a foundational recommendation. And so all the subsequent 36 recommendations in one way or another flow from those 3 foundational recommendations.
Dean, that's just wonderful, and delighted to see how important establishing access, equity, and the availability of care based on social determinants is for the recommendations of the commission. Let's get into some of the population level recommendations first. So, Dean, you served on that subcommittee. Can you highlight a few of the recommendations for policies and programs that are intended for the general population?
Right. Thank you. I mean, I think one of the successes of our commission, and there were many, was the recognition, as Bill mentioned, that we cannot just make recommendations that assume that the patient is sitting in the office. We have to be thinking about the ways in which the federal government touches the average American and how that either can contribute and accelerate the diabetes epidemic or can work as a mitigating factor to prevent the incidence of diabetes and its complications. As we all know, as practicing clinicians, issues such as the food environment, the way we transport ourselves, where we live, the attributes of our neighborhoods, all can have an impact on area level rates of diabetes and area level availability of resources to prevent or manage diabetes. And so in a very systematic fashion, we went through agency by agency of the federal government to try to determine sort of where the rubber meets the road and where there is potential areas of traction where we could influence governmental policies in a positive way for the general population, recognizing that about half of the general population has prediabetes already. So interventions that affect the general population can be very efficient in impacting diabetes incidence rates. The key agencies and departments that we focused on included the USDA, the Department of Agriculture, the FDA, the Food and Drug Administration, the Federal Trade Commission, which regulates some of our commerce in this country, Housing and Urban Development, and the Environmental Protection Agency, just to name a few, just to give a sense of how broad a scope we took. If you'd like, I can give some highlights of those recommendations or leave it at that.
Yeah, why don't you give us a couple highlights?
Sure, I'll give you some highlights from different agencies in terms of our recommendations. One of our significant recommendations had to do with the very large USDA program. It's a nutrition assistance program known as SNAP, the Supplemental Nutrition Assistance Program, formerly known as food stamps. And this was designed originally to solve a problem of hunger through the provision of nutritional food. It's about an $80 billion a year program. It's a massive federal program with about 40 million beneficiaries a year, and it's absolutely essential to the well-being of Americans. The question we pose is, how essential is it to the health of Americans, and is it doing a good job of protecting the health, or is it jeopardizing the health of Americans? As you may know, the structure of the program allows for the consumer to use his or her discretion in making any kind of purchase that he or she may want. In other words, it does not incentivize the purchases of healthier foods. As a result, a significant portion of the SNAP budget is going towards the purchase of diabetogenic foods, such as sugary sweetened beverages. And given the high cost of healthier foods, the SNAP dollar often does not stretch to allow the patient, the individual, the beneficiary, to purchase healthy foods for his or her family. And so, as an example, we recommended that sugar-sweetened beverage sales be prohibited as part of a benefit of SNAP. People can still buy sugar-sweetened beverages, just not on the SNAP dollar. And that $1 used to purchase fresh fruits and vegetables would actually be worth $1.33, so as to incentivize the purchase and make easier the purchase of healthier foods. With respect to the FDA, for example, we recommended that front of package labeling be required that would alert the average consumer, many of whom have significant amounts of health illiteracy, that a particular food is high in added sugars or fat or sodium, rather than having the consumer try to sift through the nutrition label and understand the number of grams needed for the RDA and do that math, but rather have very clear evidence-based icons that have been shown in other countries to be effective in promoting health, that be a policy taken up by the FDA.
So those are some excellent recommendations that just make a lot of logical sense for the general population to help. And Dean, you also mentioned that a large chunk of the general population actually have prediabetes and may not even be aware of that. So if we were to shift gears a little bit now and talk about the population with prediabetes, Bill, I'm going to go back to you. What are some of the recommendations then for diabetes prevention in high-risk individuals?
Thank you, Alice. As you pointed out, currently there are probably 96 million Americans with prediabetes. Fewer than 1 in 5 are aware of the diagnosis. And if you look at those who are aware of their diagnosis, only about 2% of them have enrolled in the diabetes prevention program, which is a lifestyle intervention program targeted to people with prediabetes. So one of the major recommendations of the Commission was that federal agencies work to increase awareness of prediabetes and facilitate the uptake of effective lifestyle intervention programs, including the National Diabetes Prevention Program and the Medicare DPP. And there are problems with the available programs in that they have different eligibility criteria different payment mechanisms, and a number of other differences between the programs, which create barriers to both potential participants as well as to organizations that would like to provide those programs. So we've also recommended that the eligibility criteria for the national DPP and the Medicare DPP be harmonized, and that the recognition and payment processes for the two programs actually be streamlined as well, so that if one applies for accreditation to deliver one program, you can deliver the other. We also thought it was important to put targeted diabetes prevention into the arena of quality measurement and quality improvement. The first step in any quality improvement activity is to measure processes and outcomes of care, and those things that do get measured tend to improve. So the commission recommended adopting quality measures that support screening for prediabetes, targeted interventions, and follow-up to delay and prevent type 2 diabetes. There are a lot of barriers now to insurance coverage for effective delivery modalities for diabetes prevention. We know that the programs can be effectively offered in person using telehealth and even virtually. There are barriers to payment for some of those through the different payers, and the commission would really like to see insurance coverage for all effective delivery modalities. And one of the other things that just seems remarkable is that state Medicaid programs generally do not cover the diabetes prevention program. So currently only about a dozen state Medicaid programs cover the national DPP. We would like to see state Medicaid programs incentivized to provide coverage. And finally, in addition to lifestyle interventions, we know that metformin is safe and effective for the prevention of type 2 diabetes, as demonstrated by the diabetes prevention program. Because there's no IND, investigational new drug, for metformin, there's really been no interest in anyone stepping forward to get FDA approval for its indication for diabetes prevention. And not having FDA approval for diabetes prevention is a barrier to prescribing and uptake of metformin for diabetes prevention. So the commission also recommended that the NIH contract with someone to actually facilitate FDA review and approval of metformin for diabetes prevention. So there are a number of activities that we have recommended, really targeting diabetes prevention in high-risk individuals, which we think complement the general population approach.
Right, Bill. And those high-risk individuals, as we all know in our endocrine and diabetes practices, already have the metabolic disorder that leads to type 2 diabetes. And so having an arbitrary distinction between when to intervene puts the population at a great disservice. And it's terrific to see the commission highlighting the importance of addressing metabolic dysfunction early before there's a chance for development of future disease complications. For the population that has already established diabetes, Paul, turning to you now, what are some of the recommendations for diabetes treatment and mitigation of diabetes-related complications that came out of the commission?
Thanks, Mike. I co-chaired the Treatment and Complications Subcommittee with Dr. Cal Greenleaf. Our group focused on factors that are likely to improve high-quality care for people with diabetes. Our work was really framed by the principles that people living with diabetes must be able to access and understand information about diabetes, its treatment, and potential complications, that they participate collaboratively with healthcare providers in ways that are consistent with their unique characteristics and goals of care, that they have the skills and confidence and support to perform self-care. And we also affirmed that community resources must align with patient self-management needs, and that healthcare systems must deliver high-quality diabetes care to individuals with diabetes. With that as our framework, I'd like to highlight maybe a few specific recommendations that we made. So first, we recommend that the Center for Medicare and Medicaid Services, otherwise known as CMS, should update and regularly reevaluate their eligibility requirements for diabetes devices. such as insulin pumps and continuous glucose monitors. And this process be reevaluated approximately every 3 years. One of the things that we heard from several stakeholders is that the processes that govern this can be very complicated and inefficient. In particular, because eligibility, documentation, reimbursement requirements aren't always clearly defined and consistently applied across the spectrum that includes contractors and auditors that oversee CMS reimbursements. We also, in that same regard, suggested that in evaluating the eligibility criteria for such devices, that both glycemic and non-glycemic benefits be considered, such as patient-reported outcomes, quality of life, and diabetes distress. We recommended that Congress should support our continued use of virtual care modalities. A major byproduct of the pandemic was that virtual care was rapidly adopted and accepted by both patients and clinicians, and was largely found to be successful. So we specifically proposed that telehealth waivers, for example, for diabetes self-management, education, and support, as mentioned by Bill, and that coverage for audio-only visits be made permanent. We think that will certainly improve the care of patients with diabetes. We recommended that CMS develop and implement a quality measure to assess potential inappropriate treatment or overtreatment and risk of harm among Medicare beneficiaries with diabetes who have life-limiting conditions. We felt that this has the potential to achieve the goal of reducing the risk of severe hypoglycemia and improve patient safety. We proposed that federal policies remove cost barriers to ensure that insulin is affordable for all people with diabetes. No one with diabetes who needs insulin should be denied access because of cost or inability to pay for insulin. We also recommended that the Department of Health and Human Services establish a process to determine high-value diabetes services and treatments that we believe should be fully covered as pre-deductible by health insurance, because there are so many of those that have the ability to prevent or delay progression of diabetes complications, and that by generating such a list, it should be regularly reevaluated. As an example, the Affordable Care Act requires insurance coverage for primary prevention services that the U.S. Preventative Services Task Force recommends as grade A or B. However, secondary and tertiary prevention strategies that may be very highly cost-effective, such as diabetes self-management and education and support, or eye exams or laser photocoagulation for people with diabetes, typically require cost sharing, and that can prevent access to those types of services. And then finally, we identified a series of research goals that we felt in need of study. I'll highlight just a few, such as studying the social and environmental conditions associated with diabetes and its complications, the study of diabetes prevention, type 2 diabetes prevention, potential barriers to uptake of diabetes self-management, education, and support, and implementation studies to better define models of team-based care. It was our consensus that implementing these recommendations will benefit the health of people who are living with diabetes, as well as further support the clinicians who provide their care and who advocate for access to patients' effective diabetes treatments.
Thank you very much, Paul. It's very comprehensive. And I got to say, sitting here listening as an endocrinologist, I'm nodding my head. I may not be American, but I have to say that all of the things that you speak about really translate to many parts of the world as well. So thank you, Paul, for that. Nita, I'm going to turn to you now. So as someone who is not directly involved in the creation of this document, but certainly has a strong expertise in the concepts that are laid out in the document, what are your general thoughts on it? What were some of the key takeaways for you?
I think this is a really exciting document, if a document could be exciting. I mean, I think that it was incredibly thoughtful. It really represents the multidisciplinary, multiple stakeholders that were involved in the process and are really invested in trying to prevent and treat and manage diabetes well. I think many of the ideas and recommendations are actually things that will resonate with a lot of listeners of the podcast. And they're probably thoughts that, clinicians have had as they've gone to clinic and been like, why is the world the way that it is that we have to work within these this happened. I think barriers like easier access to the DPP will resonate with so many clinicians. I practice on the south side of Chicago, and there are no DPPs in my neighborhood that I could refer patients to. Telehealth can help. So supporting telehealth recommendation is a great idea in other modalities for DPP, but true access to DPP is very much needed. I really like the emphasis on the life course, starting with the consideration of maternity leave, so to encourage breastfeeding for infants all the way through, housing and SNAP and, environmental toxins, just a very thoughtful approach to the many social determinants of health and challenges that people living with diabetes experience. And then there are other routine, just, funny things about the healthcare system, how the A1C can't be used for screening for prediabetes, how it's hard to get reimbursement from some insurers for it. It's just a little bit of a concern and something that I think people are really excited to, read about. Also, the encouragement for healthcare teams, the shortage of endocrinologists out there is very real. And I think that as people try to find specialists to refer to when they need to, trying to increase access to telehealth, expanding healthcare teams, this idea of aligning programs funded by HHS with the healthcare needs, maybe these things can help us with the endocrinology shortage. I'm not sure. So I think in general, my takeaway is there's so many great recommendations in this document. I really hope that members of Congress and the different departments actually are responsive and do something about these ideas.
So the National Clinical Care Commission report was submitted to the U.S. Congress on January 6, 2022. It's been a year since the report's been presented to the members of Congress, and I'm hoping now that each of you, Bill, Dean, Paul, might touch on what recommendations have been implemented in the past year.
I can start from the general population perspective, and just to remind people that these recommendations were submitted to Congress and to the Department of Health and Human Services. And the purpose is to foster new legislation on the part of Congress, on the part of the legislative branch, to enable these recommendations to become implemented, or on the executive branch side, to enable the existing departments and agencies, to the extent possible, to look at their administrative laws and practices and make changes that could benefit populations at risk or with diabetes. So none of this is going to happen overnight, because these kinds of legislative changes or administrative changes are going to take time, advocacy, and leadership. We have, however, begun to see sort of a corollary to our submitting the recommendations, which is we're beginning to kind of socialize these ideas with the larger number of stakeholders and policymakers, so that they begin to find themselves in existing legislative efforts and rulemaking efforts. And some examples of that, wherein the recommendations that we've made have already been taken up into existing legislation. Whether or not we can attribute it to our report or not, we cannot say, but examples include the EPA and the Department of the Interior. As you may remember, in President Biden's infrastructure bill and law, there was significant funds given to revamp the fresh water system in the United States. Right now, about 1 in 3 Americans do not have access to fresh, clean, uncontaminated tap water. And so there is a movement which would significantly improve efforts to prevent and control diabetes if people can drink clean water, to revamp that system. So a recommendation that we had made in our report, finding its way into existing legislation. At the level of the FDA, as you may know, the FDA has finally agreed that it should have some front of package labeling to alert the consumer to the nutritional content of the food in a very visible and easily understandable way. And they have agreed to initiate a front of package label. We are disappointed to have learned that it's not going to be a warning about the unhealthy things, but rather sort of featuring of the healthy and nutritious content of the particular food. So there's a little bit of a loophole that I think would need to be addressed in order to make it as effective as it's been found to be in other countries. And then at the USDA, we've seen very positive movement around something known as the Thrifty Meal Plan. The USDA's SNAP program makes its calculations around how much money the benefit involves based on some assumptions about purchasing in a thrifty manner. And these purchasing assumptions were developed in the 1950s, 60s, and 70s. And as a result, the amount of money, the budget that is calculated to give the average beneficiary is significantly less than what we know in reality in 2023 is needed to feed a family. And so the Biden administration and the USDA have updated the Thrifty Food Plan and modernized it so that the benefit more closely aligns with the reality of purchasing in today's economy. And then lastly, you may remember that the White House sponsored a very important conference on hunger and nutrition and came up with a number of recommendations to improve the issues of food insecurity and undernutrition or malnutrition or overnutrition, as the case may be, in the United States. And their recommendations, a number of them aligned closely with ours, including the recommendation around a fresh fruits and vegetable incentive as part of the SNAP program, and FDA warning labels, and other recommendations. So we're beginning to see sort of the discourse change, and that changed discourse finding its way into legislation and administrative law. But a lot still to do, Michael.
Great. Thank you so much, Dean. And Bill?
Just one general issue. The commission actually, its charge expired even before the report was delivered to the Congress. And one of our recommendations is that an Office of National Diabetes Policy be established at a high level of government to formally get together the HHS, the agencies, with some of the non-health related federal agencies, including the U.S. Department of Agriculture, Housing and Urban Development, Department of Transportation, Federal Trade Commission, Environmental Protection Agency, to really monitor progress on implementation of the Commission's recommendations and to provide future direction to activities for the prevention and control of diabetes in the United States. With respect to targeted interventions for diabetes prevention, the Centers for Disease Control and Prevention have really taken a leadership role in implementing and evaluating and certifying sites to deliver the National Diabetes Prevention Program. And they've announced that this year they will be increasing their funding to all 50 states to expand those programs and to really begin to focus more on health disparities and disparities in the uptake of the National Diabetes Prevention Program. And we know that CDC is now talking with CMS about harmonizing some of the issues related to the National DPP and the Medicare Diabetes Prevention Program. And we have spoken with NIH as well about potentially funding someone to pull together the information about metformin to submit an FDA application. So I think there is action occurring in that arena.
That's wonderful, Bill. Thank you. And Paul?
I'll briefly mention that, as Bill said, the wheels of progress in our government sometimes grind slowly, but they do grind. And so we're still hoping that the report will gain traction through those in Congress and potentially even those listening to this podcast who want to take this on and advocate on our behalf collectively. Have been informed that Medicare, which is the target of many of the recommendations that we put in the report, has taken our recommendations seriously and is considering changes to their diabetes program as a result. I don't have any specific inside information, nor do I have a timeline when any such changes may occur. On a brighter note, it's noteworthy that the recently passed Inflation Reduction Act has achieved a cap on the monthly out-of-pocket expenses that patients incur for the purchase of insulin at $35 for Medicare beneficiaries, something that we strongly advocated and are delighted to see. So that at least is one very favorable outcome. Whether or not it was actually a direct byproduct of our report remains to be determined, but certainly we're delighted to see that.
Obviously, a tremendous amount of effort and time and energy has been put into creating this incredible document. And the last question that Mike posed, I think, is a critical one. It's all about, okay, now what, right? How do those recommendations get implemented? And I think has been alluded to, the implementation is going to rely on many stakeholders, as well as, of course, the members of Congress. So I think it's worth reminding the listeners, certainly the US-based listeners to this, that you as individual citizens have a strong role to play from an advocacy perspective, but also in terms of voting and selecting who gets into Congress and reads this report and sort of implements things. So hopefully this podcast will help motivate and inspire people to take that charge. And I would like to congratulate you for creating this clearly foundational milestone. for directing future progress in the United States. And I would argue also sets a nice path for lessons that other countries can also take in terms of implementing ways of prevention, screening, treatment practices for the general population, those with prediabetes, and also those with diabetes. So on behalf of Nita and Mike, I want to sincerely thank you, Bill, Dean, and Paul, and your colleagues for all of your hard work while serving on this commission, and for sharing with us your critical insights into the process and its outcomes. This effort will undoubtedly have a major impact on the future of diabetes care, and I encourage everyone listening to this to also read the documents that are available in the February issue of Diabetes Care. And finally, thank you. Thank you very much, gentlemen, and thank you very much, Nita, for giving us your thoughts as well.